Yeah, hello everyone. Today we'll be talking about urinary tract infection. So, what we'll be dealing under the headings epidemiology, etiology, pathogenesis, and we'll just be highlighting different types of UTIs. So, what is this UTI? Is the presence of bacteria or other microorganisms in the urine or genitourinary tissues which are normally sterile. So, these genitourinary tissues are normally sterile. There you get contaminated with the bacteria, which leads to a urinary tract infection. It may be asymptomatic or symptomatic. So we have, depending based on these scenarios, we have different clinical entities. Okay, wherein a young woman with acute uncomplicated cystitis, which and again a woman with recurrent cystitis, a young woman with acute uncomplicated cystitis, adults with acute cystitis and conditions that suggest occult renal or prostatic involvement, and very other important, which will be important aspect is the complicated UTI, and uh, less former common form is a more commoner form is asymptomatic bacteriuria. So coming to the etiology, it is seen most commonly in females than in males in a reproductive age group. Okay, so when more common in the females in the reproductive age group and males 1 to 50 years, but in the neonatal period, that is, it's high in males than 1 year age group. So more than 50 years, male are at higher risk because of benign prostatic hypertrophy. So the prevalence of asymptomatic bacteriuria is approximately 5% in women of age 20 to 40 years, and 50 to 80% of women acquire UTI at least once during their lifetime. So 30% of women who had UTI will have once again recurrence of the same symptoms of UTI. So, but as in case of men, there will be some anatomical or functional abnormalities leading to UTI. So, one of the risk factors is lack of circumcision. Okay, so type and immunocompromised people, they will have elderly people. Okay, may have two conditions. Should always remember UTI or pneumonia. Okay, if there is elderly disease in the elderly, most common things will be UTI or pneumonia, and among them, if they are diabetics, anyone who's diabetics, there is a chance of 2 to 3 fold higher incidence of asymptomatic bacteria and UTI than the commoner people, that is, who are non-diabetics. So, what will be the cause? There will be poor bladder function and obstruction in urinary flow and incomplete voidings, which are the very important risk factors for this UTI. Okay. Okay. So, what's this? So, body has a defense mechanism which protects the urine from being infected. Okay, so it is usually sterile. So what is that? The elimination of bacteria by voiding. So we should always do frequent voiding whenever you feel to void. When this bladder is you feel full, you should not hold the bladder. So otherwise this may lead to UTI. Okay, so and this elimination also helps in the elimination of the urine, helps in voiding of the bacteria. Also the microorganism colonization is stopped by frequent voiding. Okay, so some of the urinary characteristics, okay, like pH and all, alkalinity. So urine proteins, dam phosphol proteins, which are protective, and uroepithelium, mucopolysaccharide layer, and it also produces cytokines, and some prostatic secretions are antibacterial. Okay, so there is a lot of host determinants like which leads to UTI are like sexual frequent sexual intercourse. Okay, after sexual intercourse, if you avoid immediately after sexual intercourse, if you avoid, then there will be less chances of UTIs. And the use of spermicidal products, they actually inhibit the bacteria which are normal bacterial colonies in the vaginal epithelium. Okay, that may lead to UTI in the woman and both in the man. So and frequent use of antibiotics. Okay, my antibiotic abuse. Okay, and suboptimal voiding habits. So there are some genetic factors which may be innate or adaptive immune response, enhanced epithelial cell adherence, antibacterial factors in the urine and bladder mucosa. Some non-secretors of ABO blood group antigens, P1 blood group phenotypes, reduced CXCR1 expression and previous history of recurrent cystitis. The biological factors will be estrogen deficiency in post-menopausal women. Okay, so estrogen also is one of the factors which will lead to UTI in the postmenopausal women, glycosuria, including from SGLT1 inhibitors. So uropathogen determinants virulence of this bacteria is of the important determinant factor. Okay. So gram-negative bacteria are most commonly implicated in the etiology of UTIs, wherein E. coli account for 75 to 90% of the cases, and less commonly gram-positive, that is Staphylococcus, which account for 5 to 15%, and Klebsiella, Proteus, Enterococcus, and Cystobacter species account for 5 to 10%. Healthy non-pregnant women, isolation of organisms such as lactobacilli, enterococci, group B streptococci, and Coccus and Staphylococcus other than Staph saprophyticus most often represents contamination in a healthy non-pregnant woman. So what is the pathogenesis? Of the cystitis? Cystitis. So we have to divide UTI into a lower urinary tract infection and a upper urinary tract infection. Above the bladder is upper urinary tract infection. Below the bladder is the lower urinary tract infection, like cystitis, bladder infection. Okay, pyelonephritis is upper urinary tract infection. Okay. So what are the pathogenesis in cystitis? It occurs in 10% of the young premenopausal women. So the more common organism isolated in 80% of the individuals is E. coli. So the infection is usually by ascending route. So recurrence rate of acute uncomplicated UTI is more common. That is 30% uncomplicated UTI is recover. So what is the mechanism behind this? Is the intracellular persistence of E. coli in the uroepithelial cells. Okay. So acute uncomplicated urinary tract infections are due to interaction of the virulent organism with the host genetic and behavioral variables, and this is supported by increased frequency of UTI in the first degree relatives. Spermicidal agents, as I said, use of that will lead to killing of lactobacilli in the vagina, which is a normal flora of the vagina.
Class.
Poor perineal hygiene are also associated with acute uncomplicated UTIs. So what is this complicated urinary tract infection? So it is defined as UTI that increases the risk for serious complications or treatment failure. So what is complicated UTIs? They differ in the pre-treatment and post-treatment evaluation and type and duration of antimicrobial treatment than for uncomplicated UTI. So most common types are nosocomial UTIs, which are acquired in the hospital. Okay, so which occurs in 5% of the patients who are admitted to the hospitals. They are actually debilitated patients who are diabetics, immunocompromised, okay, old age. So these are the factors, and who have prolonged patients with strokes, multiple organ dysfunctions, where there will be indwelling catheters. Okay, so those patients will be having catheter associated infections, which are the cause of nosocomial infection of UTI. So they present with signs of cystitis and pyelonephritis, but may also vague or non-specific symptoms such as fatigue, irritability, nausea, headache, and abdominal or back pain. So urine culture should always be performed in such patients with suspected complicated UTI. So complicated urinary tract infection, obstruction, or other structural factors like urolithiasis, ureteric stones, malignancies, urethral and urethral strictures, bladder diverticula, renal cysts, fistulas, ileal conduits, other urinary diversions, and function of Of course, some functional abnormalities like neurogenic bladder and vesico-ureteral reflex. If there is also some foreign bodies like indwelling catheter, ureteral stent, nephrostomy tube. Other conditions will be renal failure and renal transplant, immunosuppression, multi-drug resistant pathogens, and healthcare assisted infections, prostatitis-related infection, and upper tract infection in adults other than a healthy young woman. Other functional abnormality of urinary tract. So, coming to the acute non-obstructive pyelonephritis, it is obstruction infection of the renal pelvis and the kidneys. It's associated with greater morbidity, that is in hospital stay, greater hospital stay, and 20% of them require hospitalization because symptoms vary from mild illness to a sepsis syndrome with or without shock and a renal failure. There is bacteremia in 20 to 30% of cases. And these acute pyelonephritis, they complicate 1 to 2% of the pregnancies. Renal scarring is the sequel of acute pyelonephritis. Okay. So this is the epithelial picture showing the organisms. So E. coli is isolated in 89% of. Once again, E. coli is the most common organism. Okay, gram-negative bacteria are implicated, and in pyelonephritis, E. coli is the organism which is causing. Okay. Diabetes mellitus is an independent risk factor. Use of spermicide agent are also associated with higher incidence. So, patient with diabetes, there could be sloughing of papillae, which leads to acute papillary necrosis, leading to ureteral obstruction, and it can be complicated by intraparenchymal abscess formation. So, should be suspected despite antimicrobial. Patient continue to have fever. So, if the patient have continued to have fever, even on increased doses of antibiotics, then suspect renal abscess. Okay, this is most commonly in patients who are immunocompromised like diabetes. Okay, so there could be a complication in the form of gas formation within the tissue that is called as emphysematous cystitis and pyelonephritis. Once again, diabetic patients are more prone to emphysematous pyelonephritis. Okay, that is gas formation within the kidney, which leads to pyuria. Okay, fine. Gas is confined to bladder wall and cystitis and to kidneys in pyelonephritis, where the patient, they usually, if you ask the symptom, they'll complain of nematuria. Okay, air in the urine, and also pyuria may be seen. Okay, seen in patients with uncontrolled diabetes, that 90% with dehydration and ketoacidosis. Also seen in secondary to urinary tract obstruction. E. coli is most common, once again, common cause, followed by Klebsiella pneumonia. Okay. So, what is the pathogenesis? What does happen? So, there will be high level of glucose in the urine, which serves as substrate for this bacteria to grow, and there occurs generation of gas by fermentation. So, there is a chance of high mortality, where it is which is range from 20 to 70% of mortality. So, chronic suppurative process of the kidney, that is characterized by destruction and replacement of the renal parenchyma by granulomatous tissue, is called as xanthogranulomatous pyelonephritis. Okay, so this inflammatory process, inflammation may extend up to the perinephric areas. So, what are the factors affecting this? It is a chronic urinary tract obstruction, stagnant calculus, abnormal lipid metabolism, lymphatic obstruction, and vascular occlusion. So, etiology is the organisms implicated are Proteus mirabilis, E. coli, Klebsiella, Enterobacter, Pseudomonas aeruginosa, and Staph aureus. So, these are the pictures, cross picture of the kidney and large kidneys. Okay. So, prostatitis, it is one of the form of lower urinary tract infection. It may be acute or chronic. Prostatitis is mainly because infection of the prostate, that is maybe it is bacterial in origin, so it may be community acquired or can follow iatrogenic, maybe because of prostatic biopsy. So what are the manifestation? It includes the patient presents fever, marked urinary symptoms of dysuria and frequency. Urinary obstruction and suprapubic pain are also present. So the common organism implicated is once again E. coli, followed by Proteus, Klebsiella, and Enterococcus in fewer than 10% of cases. So it may lead to chronicity, where it is called chronic bacterial prostatitis, which occurs in men with persistent prostate infections. Okay, pathogens enter the prostate from the urethra and persist due to limited antimicrobial diffusion. Diagnosis is by paired culture of midstream and post-prostatic massage urine specimens. So what should you do is you should collect a midstream urine sample or following a prostatic massage. Okay. So gram-negative Enterobacteriaceae and Pseudomonas and gram-positive organisms are isolated. So sexually transmitted organisms such as chlamydia, mycoplasma, genitalium, and trachoma vaginalis are also common cause. Okay. So cure rate at 4 weeks therapy is around 75 to 89%. Okay. Coming to the commonest form, asymptomatic bacteriuria, where there is bacteria in the urine but no local or systemic symptoms. That is called as asymptomatic. Means they do not present with symptoms, but still bacteria is present. Okay, it is most prevalent among sexually active young women. Okay, which ranges from 3 to 5%. It is uncommon in young men, but its prevalence increases in men older than 65 years. Okay, in patients with impaired voiding secondary to cord injury, the prevalence is 50%. Patients with diabetes, persistent bacteria for months can be seen. So it's also prevalent in pregnant women, and if it's untreated, the patient may go to pyelonephritis, uncomplicated, maybe uncomplicated, but E. coli are isolated from these sterile samples where you have 80%, not sterile, means who are asymptomatic bacteria, where bacteria present, then most commonly E. coli is implicated most of the times. Okay, so in one more than 65 years, Coccus negative Staph aureus is the commonest organism. That is in elderly more than 65 years. Asymptomatic bacteria is most commonly seen in patients with indwelling catheters. Okay, who are having cord injury, who is having stroke. Okay, who is on any long surgical procedures which will lead immobilization and they will be catheterized. So those patients, whether it's long time indwelling catheter, so there is a cause of asymptomatic bacteria. So what precautions you should take is at least every 15 to 20 days you should need to change the catheter. Okay. So what is pathogenesis? Formation of biofilm by the causative microorganisms. Okay. So urine compounds such as TAM, phosphoprotein, and magnesium or calcium are also incorporated to the biofilm. And urease producing organisms like Proteus mirabilis and Klebsiella pneumonia are isolated more frequently from the patient with chronic indwelling catheters. How do you diagnose this? So diagnosis is mainly by microbiological and clinical criteria. The quantitative criteria where you see a urine routine and count for the organism, that is at least you get a 10 raised to 5 colony forming units per ml of an organism, or 10 raised to 2 in a catheter, 10 raised to 2 colony forming units per ml in catheter associated disease. For women, 2 consecutive urine specimens with similar cultures are recommended. 2 samples should be taken at least in 2 weeks interval. If second culture is negative, then it is taken as first sample could be contaminated. For men, 1 culture sample is sufficient. Clinical criteria, that is that person has no signs and symptoms referable to UTI. So UTI also is complicated with urinary stones. So with like the mechanism involved in this is non-infected stones may be the nidus for colonization of the bacteria, where obstructing non-infected stones may precipitate infection proximal to the obstruction. So the commonest organisms isolated here are Proteus mirabilis because of their effect of urea splitting, which leads to production of ammonia. Thus, it increases alkalinity of urine and precipitation of magnesium and ammonium phosphate. These are incorporated into the bacterial biofilm, creating a infection stones, that is, struvite stones. This stone enlarged inside may lead to complete obstruction of the renal pelvis. Effective control of infection is needed before urological intervention. Okay. So, renal and perinephric abscesses, they are uncommon suppurative infection of the kidney. So, these renal abscesses are only confined to renal parenchyma, and perinephric abscesses involve retroperitoneal fat. So 25 to 39% are intranephric, whereas 19 to 25% are intra as well as perinephric. So what is the pathogenesis? They develop after an ascending urinary tract infection or pyelonephritis and can develop after hematogenous spread. So associated risk factors, as I said, diabetes mellitus, urinary stone, or obstructive uropathy. So the etiological organisms once again implicated are E. coli, Klebsiella, and Proteus, and Staph aureus. Staph aureus renal abscesses are frequently originated with hematogenous spread. Please make a note of that. Okay. So Staph aureus is, if you isolate Staph aureus in urine cultures, then you can think of a hematogenous spread. Okay, from a distant site. So source of infection will be different. So clinical manifestation are like same as pyelonephritis. So there are some of the infected renal cysts which can lead to urinary tract infection, where again the patient presents fever and loin pain. E. coli and Enterococcus and group-based streptococcus are more frequently isolated. So how do you diagnose? Is by urine culture, urine routine and urine culture. Pyocystis is called as vesical empyema, means collection of pus in the bladder. Okay, pyocystis, collection of fluid in a patient with non-functioning bladder, occurs in patient with anuric renal failure. Okay, so clinical manifestation will be suprapubic pain and false smelling urethral discharge. So organisms are most commonly E. coli, Proteus, and Pseudomonas. So UTI in renal transplant patients. So it is also common post-renal transplant. Okay, when you do not take care of the proper urinary tract hygiene after renal transplant, it is seen in 45 to 60% of infections in patients with renal transplant. By 6 months, 70% of patients experience an episode of UTI, irrespective of gender. So incidence is highest in first 3 months post-renal transplant, which includes cystitis or pyelonephritis. So what are the risk factors? Female gender, diabetes, UTI in pre-transplantation period, prolonged dialysis, and adult polycystic kidney disease. Transplant-related are infected cadaveric donor kidney, presence of urinary stents and urinary catheters. Prevention can be done by optimal surgical technique and antibiotic prophylaxis. So UTI in pregnancy is one of the most common thing which you encounter clinically in pregnancy because of the indentation of the developing fetus over the bladder, and there will be stasis of the urine and there will be having asymptomatic bacteria, where true bacteria more than 10,000 per ml in the absence of specific symptoms of urinary tract infection. Okay, so symptom urinary tract infection are divided into lower tract, as say upper tract infections. So what are the risk factors? Low socioeconomic status, diabetes, neurogenic bladder, history of previous UTIs, structural abnormality of urinary tract, and presence of renal stones. So viral infections of urinary tract are uncommon. Occurs in immunocompromised patients. Common viruses are CMV, adeno, and parvovirus. Clinical manifestation is hemorrhagic cystitis. Parasitic infection, as you know, most common parasitic infection is Schistosoma hematobium, where the presentation will be with hematuria, which is this infection is usually acquired with after exposure with contaminated water. This infection enters the body through the intact skin, penetrates the intact skin and enter the human body. Okay. So there is immune response to the eggs of Schistosoma hematobium, which are retained in the bladder, which cause progressive fibrosis. And there is functional abnormality early in the disease, where there will be bladder neck obstruction. Later consequences are recurrent bacterial infection leading to stone formation. So infestation with Schistosoma is a risk factor for squamous cell carcinoma of bladder. Most common manifestation is hematuria. Fungal urinary tract infection is most commonly caused by Candida species. Okay, so these are usually seen in patients who are severely ill with multiple comorbidities, What are the risk factors? Risk factors will be indwelling catheters, diabetes, prolonged exposure to antimicrobial agents. So treatment is not treatment in patients who are asymptomatic. You treat patients who are severe in sepsis like neutropenia, patients undergoing urological manipulations, and indwelling catheters should be removed to facilitate resolution of candidiuria. Okay, so the most important is catheters associated urinary tract infection in patients who are having indwelling catheter because of so many conditions, neurological conditions. Okay, fine. Or there will be renal failure when we should have catheterized the patient. So it is different bacteria and symptoms in catheterized patient where there will be organisms of more than 10 to 3 colony-forming units per ml. So there will be what is the pathogenesis? Biofilm formation on this catheter is central to pathogenesis. Corti catheter also act as a nidus for the organism to enter the urinary tract. Okay. Okay, so these were about different forms of UTIs which you have to remember and helps in your clinical practice. Thank you.